Have you ever woke up in the morning with the pain in your butt? Maybe you're just sitting down and you just really can't sit on that spot because it hurts so bad. Maybe your friends have made fun of you because you walk with a weird limp. What is that? I mean, you might have a variety of different explanations for what causes a pain in your butt, but let's talk about the medical reasons. Perhaps it started out as like a tiny little ache back there, and then every time you stood up, it was like a lightning bolt right in the booty. Rest didn't fix it, icing didn't fix it, crying didn't help it. But finally, you went to a spine doctor. And they say, you have foraminal stenosis at L4 and L5. That's what's causing your pain. Foraminal what? A 65-year-old man came to my office with complaints in his right-sided gluteal region for the past several years that's seemingly gotten worse. This is the x-ray that we obtain in the office, and what we're looking at is the lumbar spine. So we're looking at it kind of like this view, just like that. This is L3, L4, L5, and the sacrum. And you can tell by looking at a spine, it's not perfectly straight. And particularly if we focus on this disc right here, the L4 and L5, you can see that on the right side right here, it's really collapsed as compared to the left side right here. If we were to superimpose this on a model of the spine, instead of being straight across, it's kind of lopsided like that. One disc is kind of crooked like that, it'll make your spine twist a little bit. Now, if we briefly talk about the anatomy of the lumbar spine and we look at it from the side view, this part where the nerve exits is called the neural foramen. It's this spot right here. And if this little hole right here is collapsed or squished down, it can pinch the nerve. So you can imagine if that disc is kind of crooked like that and we look down at this area where the nerve exits, it gets kind of cramped. And that's exactly what's going on in this patient. So now if we specifically talk about gluteal pain, there is a variety of different problems that could potentially cause this. Piriformis syndrome, SI joint pain, L4, L5, L5S1 pinched nerves, also known as sciatica, hamstring tendinopathy, hip problems, sometimes even vascular problems. You have to get a good history and physical examination from the patient to try to solve this problem. If we get a good feeling to what we think the diagnosis may be, then imaging is warranted to help us kind of close that door and figure out what the actual diagnosis is. On this patient's MRI of his lumbar spine, his right L4 and L5 neural foramina is kind of squished, so that hole where the nerves exits is smaller than it should be and is pinching the nerve. It is literally and figuratively a pain in his butt. Doctor, I thought sciatica was like shooting pain all the way down the leg, and why does this patient only have pain in that region? Not everybody follows the textbook pattern of what sciatica is, which is pain that starts in the back and radiates all the way down the leg. In fact, most patients with lumbar disc herniation, about 3/4 of them present with unilateral gluteal pain. So we have to read the textbook, but we also have to read our patients. And pain at L4 and L5 can be in the butt, it can be shooting down the leg, it can even cause numbness and weakness. But in our patient's case, it was just isolated unilateral gluteal pain with the MRI confirming the diagnosis of right-sided L4 and L5 stenosis. We did all the conservative treatment options. We tried physical therapy with traction so we can kind of try to open up that hole where the foramen is by traction, or work on exercises to help relieve that pain. He tried chiropractic treatment, over-the-counter medications, time, and even diagnostic epidural steroid injection, which did help. But what a steroid injection does is deliver anti-inflammatory medications right near the area where the inflammation is, where that pinched nerve is. So it will provide transient relief and sometimes will last a very long time. But most importantly, in my mind, an epidural steroid injection will help kind of confirm that diagnosis. So the fact that he got some temporary relief from this kind of helps solidify our going theory that his pain is from this pinched nerve. He's tried everything, so what do we do about it? Oh, I know, let's do a spinal fusion. No, we remove that whole disc and we put in some rods and screws and straighten them out. That'll fix it. Depending on the reason why the foramen is collapsed, it may not be an unreasonable solution, but in my practice, I try to start conservatively with surgery, and why not try to go in there and perform a procedure called a foraminotomy? We can go in there on the collapsed side of the disc and kind of rotor out the foramen and widen it open so the nerve has more room. Let me show you on this really cool spine model how we go about doing that. So if we look at the back part of the spine right here, we can do a procedure called a laminectomy or a hemilaminectomy. So let me explain the difference between that. The lamina is this back part of bone. So since the pain is only on one side, we don't necessarily need to do a full laminectomy where we can access the right and left side. We can do something called a hemilaminectomy where we can only remove one side of the lamina, and that will give us access to that neural foramen to clean it out. What that allows us to do is we can drill out a small part of that bone, and that allows us to stick instruments out this foramen and shave down bone spurs or any kind of disc remnants or anything that may be compressing the nerve. And depending on your surgeon's skill set, that can be open or through an incision about this big, minimally invasive where we make an incision about this big, or even endoscopic where we make an incision about this big. And all three of those approaches are reasonable options to help address that pinched nerve. Typically an outpatient procedure, it usually takes anywhere from 30 to 60 minutes and the patient can usually go home the same day. We usually have them on restrictions for about 4 to 6 weeks with reducing their bending, lifting, and twisting of their back, and within that time period, they can usually go back to full activities. And in our patient's case, that's exactly what we did. We performed a minimally invasive foraminotomy. It took about 30 minutes and he went home the same day. And when he woke up from surgery, the pain in his butt was completely gone. Now, if the pain recurs at any point in time, it is possible that he may have to undergo a spinal fusion to kind of straighten out that deformity and remove the disc and replace it with an implant to straighten the spine. In this case, a foraminotomy was a reasonable option to start, and our patient has done really well. And I want to reinforce that surgery is never usually the primary option in these cases, and we always want to maximize and exhaust conservative treatment before we recommend surgery to a patient. And if you have specific questions about why your surgeon is offering a certain procedure or what other options may exist, it's certainly reasonable to get a second opinion. Never feel like you're going to hurt our feelings because that is your right as a patient. You have to feel comfortable with your surgeon and the recommendations that they provide because guess what? It is your back. If you haven't yet, make sure you sign up for my weekly newsletter where you can get more information about your medical health directly to your inbox. Another case of patient-focused and compassionate care. Stay tuned next week and I'll go through another case.